Welcome to the Navigating a New Diagnosis Toolkit for Parents and Medical Professionals video series. My name is Jessica Ransome. I'm the health educator with the OIF. Today, we will be speaking with Dr. Bober on a number of topics related to OI. If you are a parent or family member of an infant newly diagnosed with OI, this video may be of interest to you. Dr. Bober is the director of the Nemours Skeletal Dysplasia Program at the Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware. Dr. Bober is a pediatric geneticist. His areas of expertise are osteogenesis imperfecta, skeletal dysplasia, and genetic disorders. For someone who this is their first time hearing the term osteogenesis imperfecta, commonly referred to as OI, can you explain what that means?
Thanks, Jess, for the OIF for the invitation to be here and talk. That question is a very good question, and also at the same time very basic and very difficult to answer. Osteogenesis imperfecta, from a Latin perspective, means that the bones are imperfectly formed. And in a lot of ways, that is simple and true. Osteogenesis imperfecta is very heterogeneous in the sense that there's a lot of different kinds of OI, but what they all share in common is that children and adults with OI have skeletons that are predisposed to have fractures. Their skeletons are not as strong as a typical skeleton.
For families of newborns that are doing research and learning about OI and will come across the term brittle bone disease, can you explain to viewers about the other body systems that may be affected by OI?
So, osteogenesis imperfecta and brittle bone disease are both terms that are often used to describe the same condition. And what is the commonality and what is going on is that there is a change typically in the collagen 1 genes. And these genes encode a collagen 1 protein. And any tissue or organ which has this protein in it can be affected. So really in no specific order, the skeleton is obviously affected in such a way that it can have fractures and breaks and is predisposed to have those types of injuries. But the other organs and tissues include the sclera, or the white part of the eye. There can be differences in hearing related to the bones in the middle ear. Some people have differences in their structure of their teeth and their midface. So that is the part of the face between the lower part of the eye and the top of the jaw. Collagen 1 can also be seen in heart valves in the cardiovascular system, as well as in the lung. So potentially any of these systems can be affected, but primarily problems with OI are manifest in the skeleton, and that's why the names brittle bone disease or OI, osteogenesis imperfecta, are most frequently used.
Another question that we get frequently from families that are navigating a new diagnosis, and even families who have been navigating a diagnosis for quite some time, are about OI type. OI exhibits a wide variation in appearance and severity. Severity is described as mild, moderate, or severe. With the discussion of types, for someone who is just learning about OI and discovering this new wealth of information, how would you explain OI types to them?
This is another really great question. It's a question that we often get asked in our clinic as well. And I think when you're a new parent or a new family member navigating an OI diagnosis, the root of this question really is, how is my child going to do? And what is their life going to look like going forward? And the more one learns about OI, the more recognizable it becomes that OI is really in a huge spectrum, ranging from people that walk around without any noticeable problems until perhaps they get to be 60 or 70 years of age when they have severe osteoporosis. And that can be the mildest end of the spectrum. And then there are children who are born and not capable of having enough strength in their rib cages to survive. So when we talk about OI, it's very difficult because we don't want to confuse the parents of a child who is going to do just fine versus a child who has a life-threatening version of OI. So, like many things in medicine, we sort of take this approach of mild, moderate, and severe. These are not absolute. We can talk about what the general differences are between a mild and a moderate, or a moderate and severe, but they're not absolute. They're not black and white. There's really a gray zone that exists between them. The commonality is that, again, all of these individuals have a propensity to fracture. And then what happens? How do the fractures heal? And broadly speaking, we think that people that have mild OI have fractures that heal without deformity. And that if you give that fracture enough time, perhaps 6 months or a year, you can go back to that X-ray, back to that person, and never see that that fracture ever occurred. And that's often what we think of as mild OI, fractures that heal without deformity. Sometimes there are people that heal their fractures, but you can see on their X-ray that there's some deformity. And broadly speaking, those are people that we think of as having moderate OI. Severe OI is when the fractures heal with definite deformity, and those deformities tend to progress over time. So that is, if there's a little bit of bowing in, let's say, a femur or a tibia, we expect that bowing to progress. Another thing that helps to separate these groups is size. Of course, our length, our height is in a lot of ways determined by the way our skeleton grows. And broadly speaking, milder patients are taller. Our severe patients are the smallest, and the moderate patients are in the middle. And I don't believe that the genetic test reports that come are really what we need to be using to make this determination. They can be helpful, but they're not determinative. I think we really want to look at the child, look at their development, and make this determination.
Is the type system a ranking of severity?
In a way, you know, what we've done over the years, Dr. Salentz in 1979 sort of gave this mild, moderate, severe typing a numerical system, so that type 1 is mild OI, type 4 is moderate, type 3 is severe. And that ranking system, to a large extent, was based on the frequency which he saw those different types in his office. And then we also recognize that there is this type 2 OI, which is the most severe form of OI, which often can be life-limiting due to really respiratory compromise and rib cage issues. So I guess it is a ranking system in a way, with an awkward numbering system. But I think interchangeably with these numbers can really just be mild, moderate, and severe, and that probably helps people. Again, when I said, the whole point of this really is people ask, what's going to happen to my child? Well, broadly speaking, people with type 1 have a certain path, and people with type 4 or moderate have a certain path, and people with type 3 severe have a certain path. And while we're not being absolute, we're giving people an idea about what to expect by putting them in these different types.
We often discuss types 1 through 5. What does this mean for families who have received a diagnosis outside of that scope?
We just discussed previously 1 through 4. We didn't even mention type 5. But type 5 is a form of OI that can be recognized clinically based on certain radiographic criteria. And people that have type 5 have a propensity to develop fracture calluses that are very, very big. We call it also hyperplastic callus type. Now, what's happened over the years is, like I said, 1979, we had this clinical classification of type 1, 2, 3, 4. And for the most part, these are now recognized to be caused by changes in the collagen 1 genes. But as we've gotten into the last decade or two, we've started to recognize that there are many other genetic causes of osteogenesis imperfecta. They all seem to relate back to the way that collagen 1 functions. So they're very similar. But when you do your genetic testing, they do give you different results. And what started to happen in the early 2000s was, as each new gene was identified, it got its own number. So there was type 6 and there was type 7. And I'm not even sure where we are in terms of numbers. We could be up to type 20 now, with classifying things by their molecular basis. And it's perfectly fine to categorize things by their molecular basis. But as a clinician, as somebody who's taking care of children and their families, the different molecular causes end up putting children into these clinical classifications of mild, moderate, severe, and that's what we tend to use. So I would say that there could be 5 or 6 different genetic causes of severe OI. There could be 5 or 6 or more genetic causes of moderate OI. And at this juncture, we really don't have sufficient information to know with certainty that the different molecular types should be treated differently. And we tend to treat all of the different types with the same strategies. Maybe as we go along in the future, we'll be able to be more precise. But because that doesn't really exist now, I tend to be one to stick with the clinical classification and treat people according to where we think they fall in that spectrum.
So straying away from the type conversation, when a family has received a diagnosis, are there any follow-up questions that they should ask?
Another excellent question, and I think it very much depends on the situation. Families can have a diagnosis made in utero based on abnormal ultrasound findings. Infants can be diagnosed at birth because of fractures, and infants or may not even be diagnosed. Some people may not get diagnosed to much older ages. So I think trying to find a specific question is going to be very difficult. It's going to depend a lot on the situation. I think if you have a child that's diagnosed in utero, more likely than not, that child is going to be towards the more severe side of the spectrum. And you, the family, need to have a conversation with the care providers about what their birth and neonatal care should look like. What are your wishes for your child? What opportunities exist for different types of treatment? And in that way, a birth plan can be established. And I think the toolkit has a lot of information for how you can put together that kind of team. So if the diagnosis is made after birth, the set of questions really is going to be very different. We're going to want to look at the child, look at the x-rays. We're going to want to probably do some genetic testing to confirm, in fact, that this is osteogenesis imperfecta. And then the questions that the family asked would go back to the prior set, which is, where do we think this child falls in the spectrum? And if we can get a basic determination of that, that's going to align with some treatment protocols. I think if the child, for mild OI, the most common presentation is a child who's a walker, probably around 12 to 18 months old, and sustains a fracture in the lower extremity, whether that be the tibia or the femur. And that's going to be a different experience than somebody who's diagnosed prenatally. That child certainly is going to have mild OI, and we would again want to obtain genetic testing to confirm that diagnosis, and then implement a treatment plan.
There may be points throughout an individual's life where a decrease in fractures may be noted, or families may have learned how to manage OI in a way that works for them. Can you speak to the myth of OI being a childhood disorder that people grow out of in their teens?
Sure. I think to some extent, that's not a myth. I think we just need to sort of frame it in a set of facts. And that is, OI is a lifelong condition. There's no question about that. It begins before birth and it ends with death, and people have it their entire lives. And having OI, we use our skeletons in different ways in different times of our life. So from birth until puberty, our skeletons are elongating, we're growing. And then we get into a place where we stop growing at the end of puberty, and we have a period of stability. Our skeleton tends to stay the same. And then as we get older in life, our skeleton starts to deteriorate, if you will. It starts to slow down, much like all of our body parts as we get older. So when you do go through puberty, bone strength and bone mass increase tremendously due to the hormonal effects of estrogen and testosterone and all of those things. So it is not uncommon. It is common for people to go through puberty and begin to have less fractures, let's say in that third decade from 20 to 30. That is common. However, OI doesn't go away. The fractures got less. And we expect that they will come back as people get older. And menopause happens in women, and old age happens in men. We expect that the fractures can return. So for anybody that's watching this that may be a parent of a new child with OI and think, well, I haven't had a fracture since I'm 12, please go back to your doctor and get OI care, because we want to really try and minimize the potential for fractures as you do age.
Another question that I get frequently is about blue sclera in individuals with OI. Can you explain this a bit further? Does everyone with OI have blue sclera?
Yes, blue sclera is a very interesting part of OI. But blue sclera doesn't have to be part of OI. So usually in the first year to 18 months, having blue sclera can be a typical variant. So what that means is around our iris is typically the white part of our eye. And when we look at this, it should be sort of white like a piece of paper. But sometimes it can be a little discolored, perhaps grayish or even blue like the sky, and anywhere in that spectrum. So that's a typical variation in the beginning. And then when it persists into older age, we believe that it's definitely a feature of OI. Now, we're not completely sure of why, but that scleral part of our eye does have collagen protein in it, collagen 1. And we think that perhaps it's reflecting light differently, or it's a little bit thinner and we can see through it into the structures behind it, and that's what gives it that color. It's not 100%. In fact, through some of the OIF founded or funded rather studies, we know that about 9 out of every 10 people with type 1 or mild OI has blue sclera. About 3/4 of people with moderate and severe OI have blue sclera. So that also means that 1 in 4 people do not, but still have OI. And the numbers are smaller still in the type 5s, the hyperplastic callus kind of OI. The blue sclera can be around 20%. So blue sclera is part of OI, but it can be part of just being a person as well.
I have a final question for you to close out this video. With OI being a genetic disorder, when someone hears the term genetic disorder, often the common conception is that something is passed down from a parent. Is it possible for a parent who does not have OI to then have a child who in fact does have OI? Can you explain this a bit further?
Each family's situation is unique, and it is probably worthwhile for each family to talk to a geneticist or a genetic counselor specifically to go through that information for their family. So what we're really asking the question here is about inheritance patterns. So OI can be inherited in several different ways. Typically, the major two are what we call autosomal dominant or autosomal recessive. So we mentioned previously that the gene responsible for OI are the collagen 1 genes, and there's 2 of them. One lives on chromosome 17 and one lives on chromosome 7. And if there's a spelling change in either one of these genes, it will affect the collagen protein. Now, if you have OI and you have OI caused by one of these 2 genes, you have a 50-50 chance of passing that on with each pregnancy. It's independent of sex, so it doesn't matter if you're going to have a boy or a girl, it's 50%. So if a child is born and the parents don't have OI, and it is from this gene, then we have to ask the question, where did this change arise? And that can be a complex question to answer. It can vary with between different families. The change could have occurred in the sperm that made the child. That change could have occurred in the egg that made the child. That change could have occurred at the time of conception. And if any of those choices were what happened, the chance that it would happen again, it's not zero, but it's the same chance that it would have happened the first time, which broadly speaking, we think is a number around 1 in 10 to 1 in 20,000. But it's also possible that it happened in the testes that made the sperm, or in the ovary that made the egg. And therefore, if you go back to those tissues to make another sperm or make another egg, it can happen again. And we think, therefore, that if the OI is dominant and neither parent has it, the recurrence risk is about 3%. In other words, from counting families, 3% of the time it happens because there was a change in this gonadal tissue. So that's one mode of inheritance and one way it can happen. More recently, as I mentioned before, we had these newer forms of OI that were being described. And some of these newer forms are recognized to be recessive, autosomal recessive. So those forms of OI, the parents don't have OI either, but they each carry a copy of the gene that leads to OI. So mom has a 50-50 chance of passing it on, and dad has a 50-50 chance of passing it on. And there becomes 4 choices for each pregnancy. One choice is the child is not a carrier. It has a typical skeleton. One choice is they're a carrier like mom. A third choice is they're a carrier like dad. Or the fourth choice is that they inherit both copies of the gene that doesn't work, and therefore the child has OI. So again, this is complicated. It really requires genetic testing and some thoughtful counseling and back and forth between the family and their care providers. I think this should be part of every child's care, regardless of their type, just so the family understands what would happen with the next, or what are the possibilities for the next pregnancy.
While this video discussion has come to an end, the discussion centered around OI diagnosis is not over. We would love to hear from you. If you have any additional questions, feel free to reach out to the OI Foundation at phonelink@oif.org. Thanks so much for watching.